Hi, my name is Karen Schliep, and I'm excited about sharing some research on sex and gender differences in the risk of Alzheimer's disease and related dementia. So, as many of you know, dementia is a huge public health problem, both in the United States and worldwide, with over 6 million Americans living with Alzheimer's, and this number is expected to at least double by 2060. So as prevalence increases, largely due to us all living longer, we have actually, and good news, had a slight decrease in incidence. This is findings from Denmark, but have been replicated in studies in the United States, such as in the Framingham, that followed 2 million individuals, and we see from 1996 to 2003, roughly a 9% increase in risk, followed by a change in direction in 2003 to the present of a 2% decrease annually. What is this due to? Largely increased opportunities of education for women over the last century, as well as heart health improvements such as diet, lifestyle, and pharmacotherapy. So are there sex differences? Indeed. Among those with dementia, 2/3 are women compared to 1/3 being men. How about in incidence or risk? Again, twofold higher risk of lifetime risk of dementia for women compared to men, whether you look at age 45 or 65 lifetime risk. So what are the reasons for this higher risk? Well, studies are still being done. It's not entirely clear, but for the most part, this is largely due to women living longer than men, and age is, as we know, the greatest risk factor for dementia. So as you see on the graph on the right, whether you adjust for age or in this case stratify by age, you basically end up with nearly equivalent risk for dementia at any given age between men and women. One of the most important things, though, I hope to take away from this talk is that even if women and men have the same incidence or risk of Alzheimer's disease and related dementia at any given age, the mechanisms, pathways, and risk factors can still differ. And this is very important implications for public health interventions or even for clinicians working with their aging populations and thinking of precision medicine and how you maybe want to target certain risk factors for your patients in men versus women. So these differences between men and women may be due to biology, such as chromosomal or hormonal differences, also known as sex differences, or differences in environmental, social, and cultural influences on men and women, also known as gender differences, or most likely a combination of these two. One quick note on just making sure we're all on the same page in regards to effect modification. When we think about does the strength of the association between any risk factor and an outcome, in our case, Alzheimer's disease and dementia, differ by some third factor, in our case, sex, that is when we have, in a classic sense, effect modification. And you can't just adjust for sex and gender as a confounder if we wish to tease apart this potential effect modification. One important note that every student in Epi 101 learns is that a factor can be a confounder, an effect modifier, or both, and I'll show examples in this talk of that. So let's now kind of, with this idea of effect modification and confounding, kind of think about reasons for sex and gender differences when it comes to dementia. In the first case, a classic effect modifier, we can have risk factors with the same frequency but have a stronger effect in one sex. This has been shown with the ApoE genotype, which is a risk factor for late onset Alzheimer's disease. It's been found that women that are either heterozygous or homozygous for the ApoE4 allele have a greater risk of dementia as compared to men with the same genotype. In the second scenario, we can have risk factors that have the same effect but differ by frequency. So it's just a larger contribution to how a man or a woman might develop dementia. In this case, education and smoking. Classically, men had higher opportunities for education. Thankfully, this has changed in the last century. And smoking rates, so one being a protective factor and one being a risk factor, but they were just higher in men than in women. Thirdly, risk factors can differ by sex in frequency and effects. And this is that idea that a factor could be both a confounder and effect modifier. And I will go into some detail about this with traumatic brain injury later in the slides. And then finally, there are some risk factors that are truly restricted to one sex. So we think of pregnancy in women or therapies for prostate cancer in men. So let's dial into some of these sex differences. We know that women have twice the risk of depression as men, and this is an important link to cognition as mood and memory map to the same brain regions. Prior studies show at least a 70% increased risk of AD dementia for those with depression in midlife. So we know that there's a difference in frequency. Women are more likely to have depression than men. But what about effect modification? Is there a difference in the strength of an association? Well, this was a really good recent study that just came out in 2021 looking at depression, both recent depression, that active in the last 2 years, or depression more than 2 years ago. And here you find that actually only recent history of depression was associated with higher risk of Alzheimer's disease. And this impact was stronger in females than men. Granted, it was not statistically significantly different, as you see 2.27 being within the confidence interval of the hazard ratio for men. But as we all know in epi, we are not focusing on statistical significance now. We're focusing on the magnitude of effects and the variability around those effects, and turning to our clinicians and public health research experts to help inform as to whether those are meaningful differences. So turning to our own findings, we looked at some of these sex differences between men and women in the BRFSS survey from 2015 to 2018. And here we found, similar to what I was showing earlier in regards to incidence, that we have, well, this is a cross-sectional study, so even looking at prevalence, we actually have found that there's almost nearly identical prevalence of subjective cognitive decline between men and women after you take into account age and race ethnicity at about 11%. What about risk factors, sex difference risk factors? Well, in depression, this is an important risk for subjective cognitive decline. It's one of our strongest findings of modifiable effects, with over a threefold increased prevalence ratio for women versus men. However, it was nearly identical in terms of a 3.2, so no real differences in the risk. However, if you look at prevalence, you almost find this doubling of prevalence of depression in women than men, and meaning that then it would contribute more to the population triple fraction for explaining the cause of dementia in women versus men. When we also looked at this in the VA data, this was a fun data set to look at just because I've never had a sample that I start with over 20 million individuals. Granted, they boiled down after we restricted to those only over age 45 as of January 1st, 2000. They had to have some kind of inpatient, outpatient visit in the corporate data warehouse. And we excluded all prevalent dementia because we really wanted to look at modifiable factors prior to an incident dementia diagnosis. But here we find, as again, we adjust for age and race and some other factors, and we find nearly identical incidence of dementia at 12%. In terms of risk factors, here's where we actually found a slightly higher risk of the impact of depression on dementia among men versus women. We have fairly precise confidence intervals due to the large sample size. They're not overlapping. We had significant interaction. But again, it would be turning to clinicians and public health professionals as to knowing whether this is a meaningful difference. But one thing I'd like to point out is the prevalence for both women and men among the veterans for depression is high. So regardless about this impact, you would actually see this as a really important contribution for both women and men in terms of explaining potentially dementia later on. So our next steps, at least in the Vinci data, is to replicate the Kim et al. Study, in which you really want to dial in and say, is it recent depression that is linked with increased risk of dementia? And if this is the case, then we might reconsider how important depression is. Granted, it's hugely important for many other reasons besides its link with dementia, but we really want to understand, is it a potential consequence versus cause? And then does this difference, this greater impact for men versus women still hold when we look at recent depression? And then some gender differences. We find women have traditionally had less opportunities for education. Low education is a strong risk factor for dementia. There's research, as I mentioned, to support decline in dementia incidence since 2003 due to women's increased opportunities over the last century. And then is it just a frequency issue or not? Well, there's been several European studies that actually show that education might be an effect modifier in that the risk of dementia with lower education is stronger in women than men. How about with social isolation? Well, this is something that seems to be more of an issue for men than women. Men who have never been married or widowed are at greater risk of dementia than women. Why? Well, this is thought to women being responsible for healthcare of others, and it sometimes is at the expense of their own health. And there potentially are other reasons that could explain this as well. And finally, traumatic brain injury. We know that men have higher prevalence. Think of football, think of military. But do they also have a higher risk for dementia compared to women? So turning to our findings for education, social isolation, and traumatic brain injury in our data sets, we found that actually limited education is not a real important risk factor for subjective cognitive decline. And the prevalence of limited education was actually fairly low among this national representative population. In fact, limited education was slightly higher in men than in women. But again, this is a fairly minimal risk factor, even though it is above 1 and of concern, but the prevalence is fairly low. That in comparison to social isolation, which is one of our greatest, highest population attributable fractions for subjective cognitive decline, given its high risk and high prevalence. And this is important then to look at for both men and women. So we did find that men had slightly higher risk of subjective cognitive decline with social isolation compared to women, but actually women had the higher prevalence. So this, and over 50%. So regardless, it is one of those really important factors that you'd want to consider, from a public health standpoint for addressing if you're trying to think of modifiable factors and decreasing dementia. So what about veterans and TBI? Well, this is an interesting that we also found this to have the highest risk for an incident dementia diagnosis, particularly among men, having a nearly 4-fold increased risk of dementia with TBI compared to a 3-fold increased risk for women, but still high for both men and women. Interesting enough, the prevalence is fairly low, but it was double in women than men just within this veteran population. So even though the prevalence is low, given that it is a high risk factor, it is something that clinicians and public health researchers would want to pay attention to within this population. So then finally, turning to some sex-specific risk factors, as I mentioned, pregnancy and menopause are two women kind of exclusive events that women experience, whereas potentially prostate cancer therapy would be something exclusively men could experience. Prior research is looking at hypertensive disorders of pregnancy linked to brain atrophy and cognitive decline, whereas one missing link of that is whether it's actually related to a dementia diagnosis, and more importantly, what type of dementia diagnosis. And certainly another area of research that's being done is looking at early menopause linked with increased risk of dementia, as well as androgen deprivation therapy linked to cognitive decline and risk of dementia among men with prostate cancer. So turning to our own findings, we have looked at hypertensive disorders of pregnancy and its risk with dementia, and actually found that the big driver for the increased risk is with vascular dementia rather than Alzheimer's disease. And this helps to dial into what type of dementia that we would want to be on the lookout for among women with a prior history of hypertensive disorders of pregnancy. We're turning finally to research looking at mediating factors for this sex-specific risk factor. Does hypertension, midlife obesity, midlife depression alter the relationship between a hypertensive disorder of pregnancy history and future dementia, particularly vascular dementia? And with that, I'd like to thank my collaborators and mentors for my KO1 funded by NIA, as well as my collaborators from Vinci.